Okay, we're very pleased to have the next session, the afternoon session, 3 papers, each 30 minutes, and I'll start in honor of introducing Hans Martin and a paper with Eric and John Jones on the Affordable Care Act.
All right, thanks. Well, for introducing me. I was just going to say for having me, but since I had a non-trivial impact on that decision myself. Anyhow, it's great to be able to present that, in particular because this paper is a direct grandchild of a paper of John's, as you'll see in a second. And it's also great because I can skip over some institutional details since it's directly related to Mike's paper in the morning. So if you remember, he stopped in 2012 because in 2014, the Affordable Care Act changed quite some things about the US health insurance system. And this is what we're going to model and to think about how it affected the labor supply, Social Security and savings near the end of the life cycle, so working life cycle, so after age 50. So before the Affordable Care Act, as you've seen in Mike's presentation, most US households received health insurance through their employers. Yeah, this gave them low cost and high quality group insurance. And for many of those, it was only available when they were working. Yeah. So many of those may have worked partly at least, not only for their wage, but also in order to have access to health insurance. Now, the previous evidence shows that the employer-provided insurance affects retirement. So John's paper, together with Christopher Phelan, that he also mentioned on Monday during the summer school, is the first to show that. Then French and Jones, which we build on, added the savings decision, so self-insurance. Yeah. So then many of those without employer-provided insurance are uninsured, so potentially they must work also to pay for the health care. So what did the Affordable Care Act do? Yeah. So first of all, it introduced community-rated and subsidized private non-group insurance. Yeah. Then there was a pretty large Medicaid expansion. Below age 65, before the Affordable Care Act, you could only get access to Medicaid if you were disabled and poor. Afterwards, there's essentially everybody with income below 1.4 times the federal poverty limit could access Medicaid. So these two items really are the most two important aspects for labor supply, we think. So empirically, although there's been shifts, there was little change in employer-provided coverage. Now, what are the effects of that? Well, it severed this job insurance link, because now you could purchase cheap and high-quality health insurance, also if you did not have employer-provided insurance. But at the same time, there were income-based subsidies to that, as we shall see later. Yeah, so that created potentially large work disincentives. Now there's already quite some DID evidence around, which I will mostly skip. But there's been large effects on insurance rates. So in our data, we find, for example, that there's about 5 percentage points less uninsured people. At the same time, there are relatively small employment effects. In our data, we even find an increase of 0.1 percentage points, even though this is not controlling for business cycle effects or anything. However, we find lots of heterogeneity across the wealth distribution and what will be the initial or what will be the health insurance state in our model. So let me mention that right away, how we model that. So we distinguish for employer-provided insurance between retiree insurance and tied insurance. So retiree insurance are contracts that you can keep till the end of your life. So that is, you quit your employer, you still get access to the employer's group insurance contract. That is, you still have access to community-rated health insurance. If you get a bad health shock, your premium will not rise. It will, however, be higher than if you're working because the employer doesn't subsidize it anymore. Typically, while you're working, the employers will subsidize them a lot. Now, many contracts are tied. Yeah, this is the way in Mike's paper they were thinking about it. Yeah, that is, these are contracts which you, after quitting your job or being fired, the employer has to keep access, give you access for another 18 months. But after that, you're on your own. And in our model, you would switch after one period to the non-group category. What do we mean by non-group? Yeah, that is, you don't have access to one of these group insurance plans. As in our model, you will have the choice of self-insuring, that is staying uninsured and paying out of your own assets. Yeah. Between purchasing private health insurance and potentially, yeah, if you're disabled, if you're poor, if you're above age 65, you may have access to the government plans, that is Medicaid and Medicare. Yeah, that's similar to Mike's paper. So this is now looking at heterogeneity of these effects, of employment effects across the asset and health insurance distribution. Yeah, so the retiree health insurance, for them, nothing much changes, so I leave that out here. So this is looking essentially at diff and diff estimates of before the Affordable Care Act and after the Affordable Care Act in the health insurance asset tertile cells. And you look at these different gradients. Yeah, so for the non-group category, in the lowest asset tertile, people actually work more. And the highest asset tertile, they work less. Whereas for tied insurance, it's just the other way around. Yeah, so at the lowest asset tertile, people quit their jobs. Yeah, at the highest asset tertile, they tend to work a bit more. This one will be one of the key things our model will try to explain. What's our main explanation for these small but heterogeneous retirement effects? Yeah. And that is implicit insurance, yeah, or uncompensated care. That is, before the Affordable Care Act, many people, they were poor, had access to implicit forms of insurance. Yeah, and think of the consumption floor, which we'll also use to model those. Yeah. So that is, the government guarantees you a minimum level of consumption. And if you enter the period with high debts on because of your medical bills last period, then they will equal them out and still ensure the minimum level of consumption. Yeah. All right. Yeah, well, does not necessarily equal them out. They could also be covered by the hospital directly. Yeah, this is sort of empirically what you see there. Yeah, so this is 2014, and this is American Hospital Association data. And you see the total fraction of bills that were not covered drops from about 6% to 4%. We see the same in our MAPS data. Yeah, so this is 2014, and after that, you see a large drop in uncompensated care. So what's our contribution? Yeah, so we estimate this retirement model that accounts for medical expected uncertainty, savings. What's the key novelty relative to these other papers that I mentioned is these multiple insurance possibilities. Yeah, that is staying uninsured, purchasing private non-group insurance, and then we model employer-provided health insurance, and relative to previous papers in much more detail, Medicaid, Medicare, and combinations thereof. Yeah. We have this default on medical bills, and relative to other papers that look structurally at the Affordable Care Act, yeah, the savings decisions and default on medical bills are really the key novelty. So how do we model the budget sets? Yeah, so this is for someone who's uninsured, who does not have any assets, and has $5,000 of medical expenses. You see what the consumption floor, which we estimate to be something like $1,600, does is that it always guarantees a minimum level of consumption. So if your pre-tax income is below $6,500, yeah, you will always get the consumption floor. Yeah. And after that, yeah, sort of you will get your you will get to keep most of your income, and at some point the progressive tax kicks in. Yeah. Now, when we use the model to predict the effects of the Affordable Care Act, the main thing that happens is the changes in the budget set. So first of all, as I said, one key provision was that everybody with less than 1.38 times the federal poverty limit in terms of income now is eligible for Medicaid, and Medicaid will cover nearly the full bill. Yeah. So the consumption floor really is relevant only if you have income of less than $1,600. The medical expenses will be covered by Medicaid. So then this rises, and after that point, the subsidized insurance from the Affordable Care Act kicks in. You see these subsidies are pretty generous, so you hardly pay anything in terms of the premium at the beginning, but the cost sharing subsidies drop as your income increases, and at some point, you will actually have less income due to the phasing out of the subsidy and you paying the full premium. If you're uninsured, it almost looks the same thing as before, but you have a mandate to purchase insurance. So you will incur a penalty and have a bit of less income available. So what do we find? We find that there's small aggregate disemployment effects, but they're very heterogeneous across the board. And in order to, the default on medical bills really is key for finding these small effects. So I will skip over most of these slides. Apologize for not cutting them out earlier. Just been due to organizing this conference at the same time of thinking of the own presentation. So I'll go in relative detail in the spirit of the conference through the life cycle model, and only highlight some details of the data and skip over most of the estimated parameters so I can get into how we model the Affordable Care Act and what we predict in terms of the effects. So, as an overview of the model, households get utility from consumption, from leisure, and from requests. Consumption and leisure are not separable. Yeah. So the choices are consumption, how much labor to supply, whether to work or not, and how many hours to work that we model as a discrete decision, similar to Mike and Feder, if you've been around on Tuesday. Whether to apply for Social Security and the health insurance choice. Whereas the only choice is really here whether to purchase private insurance or stay uninsured if you enter the period with non-group insurance. So whether you're eligible for the government programs, Medicaid, Medicare, will be entirely a function of state variables and other choices, in particular labor supply. So households face risk over the wages. So we have a wage process with permanent shock. Their marital status, and if they're married, they may be married to a spouse with income or not. So ours is a model of men. How long to live? They face risk over their health status and medical spending. So beyond the health status and marital status, medical spending evolves stochastically, again, with a permanent component and a transitory component. Now, government will partially insure this risk with progressive taxation, the public health insurance programs that I already talked about, then Social Security and disability benefits. So before age 65, we model the disability program in some detail. And importantly, this consumption floor, which you can think of as food stamps plus other similar programs, plus the defaulting on medical bills, whether that's covered by government programs or by hospitals directly. And then hospitals often are reimbursed by the government for these uncompensated care. Now, assets evolve in a pretty standard way. That is, we have last period's assets plus income, expenditures, and transfers, and we must enter, and the people are borrowing constrained. So income includes labor income, asset income, pension benefits, which depend on your health insurance state. So the people with retiree health insurance tend to have more generous private pension plans than others. For example, social security benefits if you apply for it, and disability benefits, which we model in a lot of detail similar to the tax structure. Now, expenditures are on consumption, of course, insurance premium, if you have any insurance, and out-of-pocket medical expenses. Importantly, these are realized after decisions are made, so you may actually enter the next period with negative wealth, because you decide to spend all your available cash on hand. Then a medical bill of some proportion hits you, you will enter the next period with negative wealth. And then the government hospital transfers simply are the maximum of, well, if you enter with negative wealth, this is equaled out. I mentioned that. All right, solution estimation is pretty standard method of simulated moment with 2 steps. It's computational intensive because we have many states and choices. We do that on GPUs. If you're interested in that, let's talk later. In terms of the data, we use the HRS for labor supply, wages, health, and assets, for pensions, and for social security. This does not give us total medical spending, which is then translated into actual out-of-pocket spending using the budget sets that I showed you before. So that we get from the medical expenditure panel survey. So this allows us to create then measures of uncompensated care and get at these budget sets depending on your insurance status. So this is important to keep in mind. So we estimate the model on pre-reform data for the 1940s cohort. So stopping in 2012, just like Mike. And then we use a younger cohort from 1945 to 1963 in order to generate these diff and diff type estimates. And to predict the reform's effect. Let me skip over this medical spending. Just believe me that it's pretty risky even after controlling for health insurance and health status. Health insurance, I mentioned that. This is a key novelty relative to previous papers, namely how do we describe health insurance policies. So we have a deductible, we have a copay rate, and an out-of-pocket maximum, and then of course a premium. So the premium for private non-group contracts is a function of the permanent shock to medical expenses. Think of it as the insurance company can observe whether you have diabetes or not, and similar permanent conditions. Of health, of marital status, and of age, because spouses tend to be insured by a family insurance. For employer-provided insurance, by law, this can only be a function of employment. That is, while you're working, you get a subsidy from the employer. If you're not working, you don't get it anymore. And marital status, again, because it tends to cover the whole family. So these are then the budget sets for uninsured people. So this is not quite the 45-degree line, but close to it. This is for retiree insurance. You see that's a pretty good deal. So you have a premium of $1,500 and an out-of-pocket maximum of $4,500. And then of private non-group insurance for someone with predicted medical spending. See, the other stuff is somewhere there in the vicinity. I don't want to go into too much detail there. What I want you to look at is what changes, how private non-group insurance changes when you have low predicted medical spending. So this is at the first quartile, I think. So it gets quite a bit cheaper. However, if you have high predicted medical spending, so this is for $1,500, $15,000. expected expenditure that will be somewhere up there. Yeah, so it gets expensive pretty quickly. Right, yeah, we estimate parameters. Yeah, so it's very handy that you cannot see that for type 2. We estimate the time discount factor to be slightly above 1. Yeah, we have this consumption weight. They all are broadly in the line what you would expect. Yeah, so for example, if we calculate the friction elasticity on the intensive margin at age 55, yeah, we get a value of just under 1/2, which is very much in line with what Hamish showed yesterday. Yeah, and sort of if we calculate based on this specification, the average coefficient of relative risk aversion for consumption, we get about 2. Yeah, and the other parameters all broadly make sense relative to other papers too. Yeah, so skipping here through the model fit for all kinds of things, employment rates, the fraction uninsured at the bottom assets tercile and the middle and the top. Yeah, so that's usually not so easy to get right because you would think that at the bottom, people value insurance more than if they can self-insure, but due to the consumption floor, this is not quite the case here, and our model gets that right. Now let's think about how we model the Affordable Care Act. Yeah, so first of all, we have the individual mandate, as I said. Yeah, then there are restrictions on private insurance policies, so it has to be community rated. And we pick the silver plan, which is sort of the most common one that's been purchased. We set the premium, the annual premium to $6,000, which we take from published records, market surveys. We model in detail the premium subsidy, the deductible, and the copay subsidies. Yeah, and this is what that looks like then. Yeah, so this is the line that I showed you before for someone with average medical expenditure before the Affordable Care Act. Yeah, now this is for different levels of income, the other 4 lines. Yeah, so this is a very similar insurance contract. Yeah, at an income just above the poverty line, this is a super good deal. Yeah, you pay a premium below $1,000 per year, and your out-of-pocket max is below $2,000. Yeah, and that rises then as income rises. At 50,000 euros, you pay your $6,000 premium. Yeah, so, but it's not unambiguous. Yeah, so for many people, if you have low predicted expenditure, you might have actually been better off before. Well, so if you have relatively high income, you know, above 35,000 or so, yeah, you would pay more under the new regime than previously. However, for those who have high predicted expenditures, so now I don't leave it off the chart, but I plot the line, you see for them it's a really good deal, these community rated plans relative to purchasing private insurance before the Affordable Care Act and staying uninsured. Yeah, and this was probably the main reason that Trump was unable to get rid of the Affordable Care Act completely, because of these people with pre-existing conditions, which also voted Republican to a big extent. Yep, this is what we, in terms of Medicaid, yeah, before Obamacare, households without dependents qualify for Medicaid only if they were disabled and with very stringent income and asset tests. Yeah, so you could not have more than $2,000 in liquid assets, I think, previously. Yeah, so after the Affordable Care Act, now any households with less than 1.38 times the federal poverty limit qualifies, and there's no wealth test anymore. In terms of financing, yeah, there was an additional 3.8% tax on unearned income in excess of $200,000 and an additional 0.9% payroll tax in excess of $200,000. Yeah, and there might have been some revenue from the mandate penalties, although these haven't been in existence for too long, didn't stay in existence for too long. Yeah, this is the graph I showed you before. Again, not the case that it's unequivocally good for everyone to move from one regime to the other. Yeah. So let me show you some statistics for insurance coverage, for employment, and for uncompensated care. As I said, we will predict the behavior of the 1945 to 1963 cohorts using our model. So the reforms come unanticipated in 2014. We'll then compare the effects of the Affordable Care Act relative to before. Yeah, so in the data, that will always be some before and after or DID. In the model, it will always be simulating the behavior without the reform relative to simulating the behavior with the reform. Yeah, so that's sort of the thing these exercises try to get at, if they could. So if you're familiar with that reform, you'll notice I didn't talk at all about Medicaid expansion states or not. Yeah, so due to a Supreme Court decision, states could decide whether they follow the Medicaid expansion or not. We use a population-weighted version for Medicaid expansion states, that is modeling the Obamacare with the reform or with the Medicaid expansion or without. Right, yeah, so these are the outcomes for uninsurance rates first. Yeah, before the Affordable Care Act, in the model, we had about 20% of uninsured people. That dropped by 10% in the model. Yeah, it dropped by only 1.7% in the HRS data. However, if you also look at other data sources, the MAPS estimate of -5% is probably a bit closer. Nevertheless, we do overestimate it. Interestingly enough, even though at no part of the model we target this, yeah, we are very close to the decline in uncompensated care. Yeah, so in the MAPS data, what I showed you previously, we saw a drop of 3 percentage points, 3.2. Yeah, our model predicts 3.4 percentage points. In terms of employment, our model predicts a drop in a bit over 1 percentage points. In the data, it actually went up a little bit. Part of that might be, though, the improving state of the economy at that time. Yeah. So these are the numbers I showed you initially. Yeah. So among the non-group category, those with low assets worked more, and those with high assets worked less due to after the Affordable Care Act. Yeah. We get that gradient, right? Yeah, the level might be a bit too low here. We get a 0 instead of an increase. Yeah, but we get that direction right, and we also get this direction right over the overestimate a little bit for the people at the in the lowest asset tercile for tied insurance. Now, how does that happen economically? Yeah, those in the non-group category. Yeah, before the Obamacare, the consumption floor or the implicit insurance acted like a tax on earnings. Yeah, if I earned a lot of income this period, or a lot of, the potential was maybe something like $25,000 or so, I was faced with the risk that I would be hit by a strong health shock. And would all be gone next period. Because the consumption floor will equal it out regardless of whether it's -5,000 that I enter the period with or -25,000. For the tied insurance people, beforehand there was a large value, especially at the lower end, of having access to health insurance down the road. Yeah, so keeping that option value of purchasing health insurance next period, which might not be there if I have a bad permanent health state, and would would have to purchase on the private market. Now, this is the willingness to pay. It's 0 at the median. It's positive on average because the willingness to pay at the top, those people with pre-existing conditions, is much larger than those who would lose due to the reform. Now, to conclude, we find strong effects of the Affordable Care Act on insurance choice. That is the subsidized private non-group insurance and Medicaid just are pretty close substitutes here. We have a modest effect of the Affordable Care Act on employment. Although these effects are very heterogeneous across the wealth and prior insurance distribution. What's really key is this default on medical bills as an alternative insurance mechanism. And yeah, as I just showed, the willingness to pay is positive on average, and people are more or less indifferent at the median. Thank you.
Comments? Go ahead.
Thank you. So I guess I was wondering, one of the things that I noticed is this realization of the healthcare shocks after you make your consumption. So a large amount of spending is sort of routine things like prescriptions or other, chronic conditions, elective measures. I guess in an ideal world, you want to include some known and some shock healthcare costs. But I wonder, can you say what are the consequences of doing it this way, and how does that sort of change the results of the model to take it as after the decision?
So I mean, to some extent, I have to guess, of course, because I didn't estimate the model in some other way. But I don't think it would make such a big difference to put in something like, maybe median health expenditures, sort of as, okay, that's taking off your cash on hand in that period right away before you take consumption decisions. Simply because this might matter for a relatively small set of people who are very close to the consumption floor. So you might be pushed into the consumption floor earlier. So there I could see this changing for the bulk of individuals who, say at 40,000 or so cash on hand and more. This won't change whether you subtract $2,000 or not. It won't change meaningfully their lifetime resources. Well, their lifetime resources are not changed at all. And the within period utility has not changed much either.
Thanks. Thank you. Thanks so much. Oh, Thomas, do you want to ask? You had a question that goes beyond the model. Do you want to ask?
Yeah, I was just curious about general equilibrium effects. I know it's a douchebag comment, but I just wonder would prices, sort of insurance prices here would change? Presumably you get more good types from the mandate. Have you any thoughts on that?
Thank you.
Yeah, that's a very good point. So before the Affordable Care Act, we make sure that insurance budgets are balanced. After the Affordable Care Act, we just take the insurance as it is, also because I think there are potentially payments from the government sort of as a form of reinsurance mechanism. Yeah, so that's the idea of the mandates, of course. Fortunately, as you might see from here, contrary to the recommendations of nearly all economists, they're fairly small. So it's not fully clear, especially if you have relatively high income, whether you actually want to insure or not. So I would say I would be more worried about it if the mandate was larger. And the effects are not, so we do estimate a version of the reform without the mandate. Also because there were some enforcement issues, etc. And that doesn't dramatically change what's going on ex post.
Okay, thank you very much.
Thank you.
Okay, the next speaker will be beaming in from Notre Dame, Chris Cronin, and he'll be talking about mental health and the reluctance to use talk therapy.
Okay, very good. Well, thanks everyone. I appreciate your attention. I wish I could be there in person. This is joint work with Matt Forsstrom and Nick Papageorge. I'll start with a little bit of motivation, just trying to explain why is it that some economists are looking at mental health. To begin with, mental health both in the US and globally has become quite a problem. Popular statistic from the United States is that 1 in 5 adults experiences mental illness each year. But really worldwide, mental illness is the leading cause of disability adjusted life years, and it accounts for 37% of healthy years lost from non-communicable diseases. Now, in addition to mental illness being kind of a growing problem, there's a really curious treatment pattern that we've noticed. For most, I throw out this big 1 in 5 adults, most of those individuals are dealing with relatively mild or moderate depression and anxiety, for which there's 2 popular treatments. There's antidepressants and there's talk therapy. And when you look at the clinical literature, it seems pretty clear that talk therapy is generally more effective than antidepressants, but it's much less frequently used. And so that's kind of what we really want to figure out with this paper. Why is it the case that patients are reluctant to use talk therapy? So I've said something about the benefits. Talk therapy seems like it's more beneficial than antidepressants. The typical answer from an economist would be, well, if people aren't using it, it must be something about the cost. And it's fairly easy to think about what costs might be associated with talk therapy that aren't as prevalent or aren't as large with antidepressants. So you can think of things like it might be more expensive. There might be a higher time cost of participating in therapy. We're going to show in the data that there's some evidence that there's an uncertainty of success, that a lot of people start therapy and then quit it very quickly. And then also there's a possibility that it's just unpleasant to sit and share your feelings with a stranger. And so really our approach is going to be to design a dynamic structural model of mental health treatment decisions that incorporates cost and benefits, which will include kind of labor market outcomes as a potential benefit of improving your mental health. And really, these models are designed to incorporate a lot of costs. And so we can kind of figure out among these costs that are listed, which are most important. And then we can start to think about counterfactual policies that would make an attempt to reduce these costs and try to close the gap between the antidepressant and therapy use. Real quickly, I'll tell you about our key findings. So first, we find that 20% of the population could potentially benefit from treatment. And really where this number is coming from is an important component of our model is going to be permanent unobserved heterogeneity that we model using these unobserved types. And essentially we're finding that about 20% of the population has a somewhat persistent mental health problem. And therefore, if they were to engage in treatment, they stand to get better. Among that 20%, about a quarter of the individuals face really persistently poor mental health, 1.6 standard deviations below the average in the sample. But these individuals actually use therapy fairly regularly. The more puzzling group is the remaining 3/4 that have more moderate mental health, and they just never, ever use therapy. And so they're really kind of at the crux of the puzzle. All right, our second main finding, one explanation for folks not using therapy is potentially that they simply don't value better mental health. We're able to show that they do value better mental health. And the way that we do that is we, in our counterfactuals, we conceive of a technology that could exist that prevented anyone's mental health from falling below the sample average. And when we do that, we can then calculate, well, what would individuals be willing to pay for such a technology? And what we show that as Americans in 2008 dollars would be willing to pay about $150 billion annually for that technology. And importantly, very little of that willingness to pay is accounted for by lost earnings. So earnings that are gained back once people's mental health improves. All right, that really leads into the next finding, which is that we can conceive of policies that would encourage talk therapy. We can think about whether or not they'd be likely to pay for themselves, because if the policies lead to better mental health and that leads to better labor market outcomes, then potentially they could. We find that that's very unlikely. For the healthiest 80, the way that we show that, we're just going to think of an extreme policy, which would be just to assign individuals to therapy. And we show that when we do that, for the healthiest 80% of the population, assignment to therapy is basically useless. These individuals are already in a good mental health state, and so there really are no improvements to capitalize on. For the sickest 20%, we show that if we assign them to therapy in one of the sample periods, and then we look at kind of their long run mental health outcomes, we do see improvements, and it comes through several sources. One is just a dynamic mental health effect. So if I can get you into a better mental health state one period in the future, then 2 and 3 periods further along, you're naturally going to be in a better mental health state. In addition to that, if I send you to therapy once, I've reduced search costs for you finding a therapist in the future. And so you're more likely to go in periods in the future. And then also we find evidence of dynamic complementarity. So if I send you to therapy in this period, you're more likely to use antidepressants in future periods, which given the context, that kind of makes sense, right? If I hook you up with a doctor and you start to share, you start to feel comfortable talking about your mental health, you're more likely to get other treatments into the future. Now, despite the fact that we find these long-run mental health benefits, we really don't see any improvement in earnings. And that's due to a kind of a combination of things. It is the case that those in better mental health are more likely to work. But this kind of sending people to therapy and then seeing what happens, the increase in long-run mental health is kind of moderate, so it kind of doesn't fully spill over into employment. And then in addition to that, for these individuals that are the sickest in the population, they're also the least likely to work, the least interested in working. So we kind of don't see that pass through. Our final finding is we conduct some counterfactual policies that are really kind of more conceivable to see if we can increase therapy in the population. And the basic finding is that the typical policy levers that have been pulled thus far in the United States, they're pretty underwhelming. So we find that reducing the financial cost of therapy and the time cost of therapy, which would be something like bringing therapists into the workplace so folks don't have to take off time from work, they have a very small effect on therapy use. The one bit of silver lining we do see, I mentioned earlier that there's this uncertainty of success. We build that into the model as a shock that individuals receive after they decide to go to therapy that kind of determines whether or not they stay in therapy. If we can lower the probability of early exit from therapy, we do see that that does generate kind of a moderate improvement in individuals' mental health. The problem is that improvement really is only realized for the sickest individuals. And again, they're kind of the most likely to go to therapy already. So if you think back to the earlier slide, I kind of laid out these possible costs that could explain why folks aren't going to the therapy. We've essentially ruled out 3 of them as being important. What's left, basically the model saying the lack of therapy use is explained overwhelmingly by disutility, which in a model like this is a little bit of a disappointing result because, as you know, if the coefficient on a choice variable in the utility function in these models is essentially a constant term or residual. It's basically capturing what we can't explain, right? So with that, I think it's important to point out, this could just be legitimately the answer to the question, right? It could just be the case that people simply hate talking to a stranger about their feelings. And the reason folks don't go to therapy and do use antidepressants is because going to therapy is really uncomfortable. It could also be the case that the uncomfort comes from pressure from the outside. So the idea that there's a stigma associated with going to therapy, and that would be captured by this utility term in our model. Where we really hope that this paper will kind of lead the literature ahead is to say, well, those are potential answers, but there are alternative answers that are kind of outside of the typical rational expectations, full information approach to the model that could also explain this. And really there's a need for more exploration on the topic. A potential example of that is that maybe there's just systematic bias and beliefs about the productivity of therapy, despite the fact that the clinical literature makes it pretty clear that people get better when they go to therapy on average. Maybe folks just don't know this or they don't believe it. And so that when in our model, when we assume that that's true, maybe that assumption is incorrect. Another possibility is that the treatment effects that are coming out of the clinical literature, maybe they're just wrong. I will say that we've read a lot of the literature. A lot of researchers are doing a very good job of trying to conduct their studies in kind of naturalistic settings with existing clinics where you want to believe the results, but there's a possibility that just the types of clinicians that offer therapy in clinical trials, maybe they're just better than your average therapist. And so when you go into kind of the run-of-the-mill therapy that you get out in the wild, maybe it's just not as good as what we're seeing in the clinical literature. Okay, so with that, I'll kind of talk about the data. and then I'll get into the model. We're going to use MEPS data, which I would imagine a lot of people are familiar with. This is a big panel data set in the United States that's been collecting data on individuals for a long time. Individuals report a bunch of labor market information, and then also information on their medical spending. Each year, a new nationally representative cohort of Americans is added. Individuals are interviewed 5 times over a 2-year period. We're going to have a labor market component. We don't really want to deal with schooling, and we also don't really want to deal with retirement. So we're going to restrict our sample to 26 to 55-year-olds, which means we're going to have about 200,000 observations that we're working with. If I had more time to talk, I would really kind of flesh out some of these motivating features of the data, but for the sake of time, I'm just going to hit the highlights. The first is for this age group. Mental illness is really synonymous with stress, anxiety, and depression disorders. So if you look at the ICD-9 codes that are reported in the MEPS, and you just look at this sample, and you look at among all individuals that have any mental illness, over 90% of them are essentially reporting stress and anxiety. So for this subset of the population, you should really think, when we talk about mental illness, this is what we're talking about: depression and anxiety. This is not coming from MEPS, this is coming from the clinical literature. On average, therapy is more effective than antidepressants for mild to moderate depression and anxiety. There is a wealth of information, a ton of studies on antidepressants. There is even a large number of meta-analysis that are very highly cited, and it's really kind of shocking how consistent Kirsch and Ciapprini paper, they all find a standardized effect size of antidepressants of about 0.3. This other paper is looking at anxiety drugs and also finds an effect size of 0.3. So it's just really consistent across the literature. With psychotherapy, the results are more mixed. On average, the effect size that's reported is about 0.6, and even among the studies that kind of run a horse race between antidepressants and psychotherapy, kind of consistently they find that talk therapy is more effective. The third motivating feature, as I alluded to earlier, many individuals in the data, we see them go to therapy once or twice and then they quit. And so kind of how we're looking at that, we start by taking the data and we just line up therapy visits, which we can see the date on. We line them up chronologically. And then anytime we see a 2-month gap in therapy visits, we draw a line. And then between those lines, we're going to call that a therapy episode. Okay. And then if I plot the number of visits in therapy episodes in a histogram here, you can see that almost 40% of the time, individuals are only going to 1 or 2 visits before they have a long gap in their visits. We're going to call that discontinuation. So any therapy episode with less than 3 visits. When we first saw this in the data, we were really surprised by it. And we kind of struggled to explain what was going on. And when we turned to the psychology literature, we actually found that there's a wealth of literature on this problem. And this is actually a huge problem in talk therapy, that not only is it hard to get people to go to start with, but really a ton of people quit. And to say that, roughly 40% or approaching 40% of therapy users will try it and quit within the first few sessions is well documented in the psychology literature. There's a couple potential reasons for this. One explanation is you have kind of rookie therapy users that they're willing to give it a try. They go to a couple sessions and they realize, I just hate this, or I'm not ready to kind of unpack these emotions yet. There are also experienced therapy users that will go to a new therapist and they realize I just really don't sync with this person very well. We can't observe the identity of the therapist or the number of prescribed visits in the data. So we wish we could kind of disentangle those two stories, but given the data, we can't. Where this is going to be relevant for our model is we're going to model this as a post-decision shock. So essentially, individuals are going to have to make a decision about whether or not to go to therapy, knowing that after they make that decision, it might turn out to be unproductive therapy that they're going to drop out of early. And so they have to internalize that probability when they're making their therapy decision. All right, last motivating feature. Therapy is used much less, about 4 times less than antidepressants in the data, and it's very unlikely that this is due to prices. When we look at the prices that are reported in the data, a 6-month supply of antidepressants is roughly equivalent to a 6 months, the 6-month cost of going to therapy. There's a few reasons for this. In the data, insurance is a little bit more generous for therapy. Also, this 0.3 means that some of the people who are going to therapy are only going to 1 or 2 sessions, and so that lowers the cost. But we're going to end up finding with the model that prices don't matter very much. When you just look at the raw prices in the data, it's not all that shocking. Okay, so with that, I'll get to the model. In the model, a forward-looking individual will make a sequence of decisions with respect to employment and mental health treatment. The objective is to maximize expected lifetime utility. Think of a decision period as being about 6 months. So an individual enters a period, and at the beginning of the period, they're going to make choices about whether or not to take prescription drugs, whether or not to go to therapy, and the extent to which they are employed, so full-time, part-time, or not at all. If they decide to go to therapy, they'll receive this post-decision shock that determines if that therapy was good or bad. If they have a good therapy visit, that's going to improve their mental health, and it involves a larger number of visits, so the financial cost is higher. If it's a bad visit, it doesn't improve their mental health, and the cost is lower. After receiving that shock, state variables will be updated, so mental health moving into the next period, and experience, which is deterministic, will move into the next period. And then payoff variables in the future, wages and prices, will be revealed. If we think about flow utility, an individual's utility from a particular choice in period T is going to be a function of numeraire consumption, which is determined by disposable income, which is a function of the employment choice, less the spending that they have on these 2 types of treatment. Both of the treatments enter the utility function directly and interactive with a number of variables. So this would say that the impact of therapy is going to be different for someone who was in therapy last period or not. That accounts for the idea that there's kind of search costs that exist in starting therapy. Also, the extent to which I like or dislike therapy will be affected by my employment. This is the main way that we're measuring time cost. So you can think someone who's full-time employed, they have less disposable time with which to go to therapy. And so the cost of going to therapy for someone who's full-time employed is likely to be greater. We also allow employment to enter directly, which captures the notion that individuals like leisure, and will allow those effects to vary by an individual's mental health. And then mental health is going to enter the utility function directly. This mu term is going to be, you'll see throughout the model, this is how we're capturing permanent unobserved heterogeneity. It's what's going to allow the errors in the model to be correlated. In terms of transitions and payoffs, I mentioned they're going to receive this post-decision shock that'll determine whether or not they discontinue treatment. We are modeling that discontinuation as a function of observables. So when I'm making the therapy decision, not only will I know that I discontinue with some probability, but I'll have some sense of how my observables affect that probability. We also model mental health as a function of prior mental health, my treatment decisions, whether or not I discontinue, and then exogenous observables. I've highlighted these treatment variables because we're not estimating the productivity of treatment internally in the model. The reason we're not doing that is because we've got a really severe selection problem. So here I'm showing mental health in period T-1, and then in the columns, mental health in period T. So if we focus in on one of these rows, this says that if I'm in the worst mental health in last period, then when I go forward 1 period, the individuals who were using antidepressants actually have worse mental health than those that aren't. And the same for talk therapy. Those who were using talk therapy, even conditioning on prior mental health, have worse mental health now than those that don't. And this is essentially because, people are only reporting this mental health every 6 months. So between these 2 reports, I'm going to have individuals that get a bad mental health shock that leads them to have worse mental health in the future period, and it leads them to consume more treatment. So it's a typical kind of health production function selection problem that we tried to overcome with various exclusion restrictions, and we just kind of never were able to. So our solution is we're just going to use treatment effects from the clinical literature. This 0.6 and 0.3 that I referred to earlier, they're standardized effect sizes. So in order to scale those for our model, we need to multiply those by the standard deviation of our latent mental health here. All right, we're also going to model wages as a function of mental health and experience, which is pretty straightforward. And then we'll model out-of-pocket prices for both prescription drugs and for therapy. Because of insurance, people frequently pay $0 for these treatments, and so we have to model these using kind of a 2-part model. All right, this is our value function. So discounted present value of a choice in period T is a function of contemporaneous utility, my error term, and then all the stuff that I don't know. So when I make a particular choice in period T, what don't I know? I don't know how my mental health will evolve moving one period forward. I don't know what wages and prices will be in the next period, so I have to integrate over all of these things. Once I know mental health, wages, and prices, the last thing I don't know about next period is what my preference draw will be. So this is what defines my Emax function. We're going to do what's fairly standard is we're going to assume that errors are type 1 extreme value. So that gives me a closed form for my Emax, and it gives me a closed form for my choice probability. Other just details about estimation and the dynamic programming problem. We've got a couple of continuous state variables, so we'll solve the problem for every individual. We're going to close the model with a simple terminal value function that's going to be determined by mental health, experience, my choices in the last period, and then we'll allow all of those to vary flexibly with age. Discontinuation, as I referred to earlier, it's going to imply that there are no mental health gains in the next period, and it's a lower financial cost. Notice that my value function is conditional on wages and prices. If I don't work or if I don't select treatment, I won't observe wages and prices. So those things need to be integrated over when I calculate choice probabilities. We'll estimate via full information maximum likelihood. And I wish I had more time to talk about how we're using permanent unobserved heterogeneity via discrete types in the model, but hopefully for this crowd, you all understand what that means. But that's kind of critical to our results, is identifying these unobserved types and then thinking about how they really categorize mental health groups. Okay, so this is my quick outline of results. I'm not going to show parameters, but I'll just kind of highlight the main finding from the parameters. So regarding treatment, we're finding that holding future mental health constant, individuals derive disutility from antidepressants, but even more disutility from therapy, which kind of isn't surprising given that therapy's 4 times less likely to be used than antidepressants. We find that past therapy lowers the current therapy disutility, which implies that there are search costs into these treatments. We find that past antidepressant use lowers current therapy disutility. That's our evidence of dynamic complementarities. And the same is true for antidepressants. So past antidepressants lowers current antidepressant disutility, and past therapy lowers current antidepressant disutility. We find that employed individuals derive greater disutility from treatment, and that this effect is both larger for full-time employees and the effect is larger for psychotherapy, which implies that there are time costs that are associated with therapy. Regarding employment, we find that holding earnings constant, individuals derive disutility from part-time employment, but more disutility from full-time employment, implies people value leisure. Past employment lessens current employment, so there are switching costs in employment. Employment disutility decreases as mental health worsens. There's some reasons to believe that we would find that given some of the theoretical literature. So this paper essentially posits that a reason that we would expect individuals with poor mental health to work less is that part of the kind of depressed state is individuals undervalue kind of how productive they truly are. And so that would lead someone to potentially select out of employment. Regarding mental health, we find that individuals derive disutility from poor mental health, that poor mental health in the past lowers current mental health. We do find that wages are decreasing as mental health worsens, but those effects are incredibly, incredibly small that you should really think that they're essentially zero. So we're really not finding much evidence that mental health lowers wages. The main way that mental health is affecting employment or earnings is through the employment decision. If I were a good economist, I'd show you where the model fits. I'm not so good, so I'm just going to show you the one place that it doesn't fit very well, because I think it's kind of instructive for what's going on in the model. So what I'm showing you here are talk therapy rates across the mental health distribution. So this says that for someone who's in the worst mental health state, 20% of them are using talk therapy. For someone in the worst mental health state, almost 50% are using antidepressants. In the model where we don't allow for unobserved heterogeneity, remember, we have this problem in the data that mental health is very persistent, but at the same time, we're imposing on the model that treatment is very effective. Those two things are kind of at odds, right? If individuals who are in bad mental health states are going to treatment, they should be getting better. And so when we don't have unobserved heterogeneity in the model, we have a really hard time fitting that pattern. What unobserved heterogeneity does for us is it kind of allows us to explain those conflicting ideas that therapy is both productive, people use it when they're in bad mental health, but at the same time, mental health is fairly persistent. So when we add these unobserved types, what we end up seeing is the model does a better job of explaining or a better job of predicting people using treatments when they're in the worst mental health states and less so when they're in better mental health states. All right, regarding permanent unobserved heterogeneity, we're allowing for 4 discrete types. The 2 most interesting types are types 1 and 2. You can see that type 1, these individuals make up about 5% of the population, and they are in a bad mental health state. So 60% of the individuals are in the 2 worst mental health states. You can compare this to type 3 individuals. It's almost 3/4 of the population. They're in a much better mental health state. So for these that are in a worse mental health state, they are fairly likely to use treatment. So almost 40% of them use therapy over the life of the survey, and about 65% of them will use antidepressants. For type 2 individuals, you can see they're in a much better health state than type 1, but they are in a worse mental health state than type 3, and they're very unlikely to use treatment. And they're actually less likely to use treatment than type 3 individuals who are in a better mental health state. Okay, so now for our counterfactuals. The first thing we're going to think about is, do people actually value good mental health? And the way we're going to get at that is, as I mentioned earlier, we're going to introduce a new technology that guarantees that mental health doesn't fall below the population mean, and it's totally costless. So the idea is, anytime someone's health would fall below the population mean, they would take this drug and they would immediately be better. So we can run a simulation when this technology exists, and then go back to our baseline simulation and say, what would individuals be willing to pay for it? We separate it out by types. If you first look at the black bar, with the black bar, we're assuming that everyone's income is held fixed. So these type 1 individuals are unlikely to work. They have lower income if we allow income to vary across the types. So if we hold income fixed, you can see that these type 1 individuals are willing to pay a lot, over $4,000 a year for a technology like this. If we look at the speckled bar, this is allowing incomes to vary. A big thing I want you to see from this picture is that most of the population is type 3. And when we look at type 3 individuals, they're willing to pay some money for a technology like this, but the earnings they get from the technology is really, really small. Okay, because of that, when we aggregate up to say, what is the population willing to pay for this technology? Now I'm reporting in $2,002. You'll see why in a second. They're willing to pay an aggregate $103 billion, but very little of that comes from increased earnings from better mental health. Okay, the reason I'm pointing this out is we actually have a target in the kind of already in the literature to think about how is our model doing compared to what exists. You know, the American Psychological Association, the number they tout, they say that lost earnings from mental illness in the United States totals about $190 billion. We're finding that it's 16. And when you go back and you look at where they're getting this number from, it's from kind of like a very basic epidemiological study where they don't worry about the endogeneity of mental illness. And so I think part of what we're doing in this paper is saying this is kind of a ridiculous number. If you want to kind of scale this number against a paper that's a little better, this Ricci and Chi paper finds that obesity costs in the US are about $42 billion in lost productivity. So we're still even smaller than that. All right, our second counterfactual, we're going to ask what's the most we could expect of a policy designed to encourage therapy. So we want to think of kind of an extreme policy to give us an idea of, is there any scope for improving mental health outcomes using therapy-based policies. The policy we're going to consider is just forcing people to go to therapy in 1 6-month period. We'll allow for discontinuation, and then we'll observe what happens to their behavior over the next 1.5 years. When we do that, we find that the average mental health gain for type 1 individuals, sorry, that should be updated, it should say about 14%. For type 2 individuals, it's about 6%, and then much lower for these types 3 and 4 who are in a better mental health state. So that's average over the next 1.5 years. When we think about the sources of these increases, we can break up the type 1 and 2, and we can look at each period what's happening. So you can see in the first period, I've forced these individuals to go to therapy. So the probability, so 100% of them are going to therapy. If I look out one period, because I've reduced search costs, you can see that these individuals are 150% 150% more likely to go to therapy than they would have otherwise. They're also 36% more likely to take prescription drugs than they would otherwise. And this leads to a 13% increase in their mental health in the next period. Now,
You got 1 minute left.
oh, okay, thanks, John. Okay, all right, let's see, what should I skip to then? Let me skip to the counterfactual policies that we run. So the 3 things we do, we're going to make therapy free. We're also going to reduce time costs, and we're going to eliminate this possibility of discontinuation that I talked about earlier. The one that really matters is getting rid of discontinuation. So for these type 1 individuals, I get a big increase over the next 2 years in their talk therapy use when I get rid of this possibility of discontinuation. It leads to a big increase in mental health, an 18% increase. Okay, so I'm out of time, so we do a bunch of robustness. You can look at the paper to see what we do there. But again, we design and estimate a dynamic structural model of mental health treatment and labor supply decisions. We find that therapy is very productive and few people use it. It's mainly due to a large utility cost, and we find that time and financial cost aren't critically important. Okay, that's everything.
Yeah, so you'd focus on unobserved heterogeneity in terms of preferences, but I was wondering if you could fit the same facts with heterogeneity and treatment effects. So some people have a very high return to talk therapy, others have a very low return to talk therapy. And would you be able to match the same facts if you set it up that way?
Yeah, I think the answer is potentially. We played around with that early on when we were trying to estimate treatment effects internally. The problem is this selection problem in the data is really, really severe. So anytime we tried to estimate treatment effects internally, which then when we were doing that, we could allow for heterogeneity in treatment effects. Anytime we did that, the model could only rationalize the data by saying there's lots of people that are made sicker by going to therapy. So we never really hit a specification where we could both, use these external treatment effects, but also allow for heterogeneity. But no, I take the point that's a possibility. Now that said, the clinical literature is reporting average treatment effects, and the treatment effects are quite large. So to fully explain this pattern using heterogeneous treatment effects, I think we would have a difficult time fitting the pattern.
Just one other question. Chris Farrell asks, I'm wondering about non-monotonic effects of treatments. Could you get worse before getting better?
I think so. Potentially, yes. If we were estimating a higher frequency model, I think that would be a good route to potentially go down. Given that this is a model that's 6 months in length, most of the stories that you hear about people get both with drugs and with therapy, most of the stories you hear about people getting worse before they get better, it's over a relatively short time frame. So with therapy or with drugs, you often hear that it takes 3 weeks or so for the medication to really kick in and make people better, and also for people to kind of figure out what side effects they need to manage. So I think given that it's a 6-month time period, kind of smoothing over that potential path seems okay.
Thanks again. Very interesting talk. Really appreciate it.
Thanks, everyone.
To the last paper in the session. It's by Ami Ko and Minsu Chang, Marital Transitions, Housing and Long-Term Care in Old Age.
Okay, cool. So hello, everyone. Thank you very much for adding our paper to the program. I wish I were there too, in person. So today I'll talk about this paper joint with Ami Ko at Georgetown. So substantial progress has been made to understand why retirees hold on to substantial amounts of wealth in late life, which is known as retirement savings puzzle. An existing explanation for this puzzle include large medical expenditure risk at old ages and bequest motives and so on. And looking into the data, we noticed that most of retirement wealth is in housing, and there is stark difference in de-saving of housing wealth by marital status. So we found that married retirees de-save housing wealth at a much slower rate than their single counterparts. Understanding how marital transitions affect housing decisions of retirees is important for policy reform evaluations For instance, welfare programs often distinguish housing from liquid assets and treat married and single individuals asymmetrically. So from now on, I'll show you some motivating figures based on Health and Retirement Survey, HRS data. And all the figures are based on health and retirement studies from 1998 to 2014. The figure shows the life cycle profile of median housing asset share that's defined by housing assets divided by total assets. On the left side, it shows the housing asset share for currently married couples. And there are multiple lines categorized by permanent income quartiles. And here, permanent income is based on the average income over retirement period we consider. Darker shades represent lower income groups. On the right side, it shows the housing asset share for currently singles, and we include individuals who are widowers, divorcees, and those who have never been married. For these figures, we can see that couples desave housing assets much faster than singles. Another motivating figure suggests that marital transitions play a huge role in explaining home ownership rate patterns. This figure shows how the average home ownership rate changes by the years since spousal death. And the sample consists of initially couples who experience spousal death and never remarry. And around time 0 here, this is the year when spouse died. And we can see a big drop in home ownership rate around the time of spousal death. So this is a motivating figure for us to infer the marital transition seems to be significantly correlated with retirees' housing decisions. So given these motivating facts, we are trying to answer how marital transitions affect home ownership and retirement. We will focus on the following 3 channels, which haven't been comprehensively studied in the literature. So the first channel we consider is regarding the long-term care prospects. So while most disabled couples rely on spousal care, singles are much more likely to enter into a nursing home. So we conjecture that there could exist complementarity between spousal care given and home ownership. The reason is because home modification to facilitate spousal care provision can be easier for homeowners than renters, for example. So if there exists complementarity with spousal care, then this may explain why couples' home ownership is a lot higher compared to singles. The second channel we consider is regarding Medicaid, that is means-tested public insurance for formal long-term care costs, such as a nursing home. Medicaid treats houses asymmetrically in its assets test for couples and singles. And the gist is that housing assets are almost always counted against eligibility for couples, but this is not the case for couples. So this could lower the value of home ownership for singles relative to couples. The last channel we consider is about different bequest motives between couples and singles. Houses as bequests may be more valuable than when they're left to a surviving spouse than to children. And this would strengthen home ownership among couples compared to singles. Empirically, and I'll show you in a couple of slides, children are likely to, the singles are likely to liquidate their house when there exists increase in mortality risk, whereas couples don't liquidate their housing. So what do we do in this paper? We first document descriptive evidence on how marital transitions affect home ownership through long-term care, Medicaid, and bequest motives using regression analysis. And then we develop an estimated life cycle model featuring home ownership, spousal care given, and savings decisions of retirees. The model is a collective model and it incorporates uncertainty regarding health and mortality risk. Given the estimated model, we conduct the decomposition analysis by shutting down each of 3 channels we study in this paper. And we study which channel explains the difference in home ownership between couples and singles the most. What we find that's interesting is that dominant mechanism varies by income groups. We also conducted counterfactual government policies, including spousal care subsidy, which turns out to be welfare improving while almost budget neutral. And then we also experimented with changing the Medicaid's homestead exemption. So there are two strands of literature that's related to our paper. There is a huge literature on old age savings and also family long-term care. For the sake of time, I'll only mention two papers before I move on. So there's a paper by Dinardi, French, Jones, and McGee in 2018, where they studied different savings motives for couples and singles. In their paper, they treat all the assets together by pooling together. But as we documented, most of the difference seems to come from the housing assets. So we will explicitly model housing different from non-housing assets. At the same time, we will also incorporate the interaction between home ownership status and spousal caregiving. Another paper that I'd like to mention is Barzek and Kredler paper, where they build an intergenerational model to study the home ownership rate and the children's caregiving decisions. However, married couples rely mostly on spousal care when one becomes sick, so our paper will explicitly study this margin. Okay, so then before we go into the regression analysis, let's first look at how different are long-term care arrangements between couples and singles. So here, this table is also based on HRS data. The sample consists of disabled individuals who received long-term care. So for care provision, we can see that spousal care is dominant for couples, and for singles, caregiving from children is dominant. In addition, we can see that singles are more likely to use nursing home cares, so they face higher nursing home care risk. Notice though that nursing home utilization for couples is not at all zero. It's about 30%. So that's why Medicaid will still be relevant for married couples too. To better look at the relationship between spousal care and home ownership, we conduct regression analysis. We conjecture that spousal caregiving strengthens home ownership. In other words, complementarity between spousal caregiving and home ownership status exists. So here, suppose the conjecture is true, then individuals will be more likely to sell home once their spouse dies if they provide spousal care to their deceased spouse. The key dependent variable is whether newly become widows sell home upon spousal death. Key control is the provision of spousal caregiving before spousal death. And we also control for individual characteristics such as health status and also income, year and birth cohort fixed effects. For the sake of time, I'll summarize the key result in one sentence. We find significant and positive correlation between caregiving and home sales upon spousal death. Let's move on to our second channel of interest regarding Medicaid. Medicaid is again a means-tested public insurance program run jointly by federal and state governments, and it covers formal long-term care costs for eligible individuals. While Medicaid typically does not count housing assets in determining eligibility, it requires states to recover Medicaid-financed long-term care costs from the beneficiary's home when house is no longer home. In other words, when the beneficiary enters nursing home or dies. But there is major exception. The recoveries from home are strictly prohibited during the lifetime of a surviving spouse. This suggests that couples may qualify for truly free Medicaid benefits by holding assets in housing. So we run regression to check the second channel regarding Medicaid. Our hypothesis is that individuals are more likely to sell home upon spousal death. The hypothesis is that individuals will be more likely to sell home upon spousal death if their deceased spouses were Medicaid enrollees. In the regression, the dependent variable is a dummy on selling home upon spousal death as before, and the key control is a dummy on relying on Medicaid before spousal death. Then what we get is significant and positive correlation between Medicaid receipt before spousal death and home sales upon spousal death. Now we move on to our last channel regarding bequest motives. We conjecture that housing as bequests are more valuable when they're left to a surviving spouse than to children. We set up a hypothesis that in response to an increase in mortality risk, couples will be less likely to sell home than singles. And we proxy the increased mortality risk by using self-reported changes in health. And what we found is that by running a regression, we obtained a result that singles are likely to sell home in response to an increase in mortality risk, while couples don't. Okay? So this sort of provides empirical evidence for us to justify to have different bequest motives functional form in our structural model between singles and couples. So now let me move on to the model summary. Let me give you a 2-page summary of key ingredients of our life cycle model. We need a structural model in order to disentangle the significance of each channel we consider and to conduct a counterfactual welfare analysis. So everybody starts as a retired couple and they face health and mortality risk, and they transition to single retiree when a spouse dies. We consider collective household framework for married couples decision-making. This is because we'd like to incorporate different savings motive between husband and wife. The wife will have stronger incentive to save since she has longer life expectancy and longer retirement periods to finance. By the time she becomes disabled, she's likely to face higher formal long-term care risk because she tends to outlive her spouse, so there is no access to spousal care. So we use collective model in order to sort of capture this tension between husband and wife. And then our floor utility U is depending on consumption C and housing service H. For caregiving wives, we have additional this utility term regarding the spousal care, and we denote this with PSI. And we allow this PSI to vary between home ownership status. So that's why this PSI parameter is subscripted by home ownership status. So if there exists a complementarity between home ownership status and spousal care, this PSI, this utility parameter, will be differently estimated between homeowners and renters. Okay? So it's not that we're hardwiring the complementarity between home ownership and spousal care. We will let the data variation to tell us about the complementarity. Okay. And then we model bequest utility differently for singles and married. The key is that singles only value bequeathing liquid assets after liquidating their houses before they die, whereas married couples, if one spouse dies, then that person gets the bequest utility for differentially for non-housing assets and housing assets. In our model, households make consumption and savings and housing decisions. Homeowners decide on whether to keep or sell house, and renters decide on the value of rented property to live in. Renting is absorbing state, and we also model premium on home ownership, transaction cost in liquidating house, and economies of scale in couples consumption as commonly done in the literature. In terms of long-term care arrangements, disabled husbands can receive spousal care. However, wives have to rely on formal long-term care. Singles use formal long-term care if and only if caregiving from children is not available. And we can proxy this information from one of the HRS surveys question asking whether the person expects to get the care from their children when that person becomes sick. Our model has no borrowing and no reverse mortgages. A reverse mortgage in reality has very little demand and less than 3% of eligible population. And Medicaid is incorporated as a consumption floor in our framework, and we carefully model homestead exemption that's given to couples only. So if we go to the detail of this formulation, if you look at the qualification rule for singles in the second bullet point, singles qualify for government transfers if a tilde cash at hand after housing and long-term care decisions falls below this A bar threshold. And this A bar threshold will be different depending on the nursing home status and also the marital status. Okay. So one thing to note is that in the first line, when the single person is not in the nursing home, then for this person, A bar is A bar NH equals 0. It's only depending on A tilde. But if that person is in nursing home, then home is no longer home for that person who enters nursing home. So in terms of eligibility condition, we also add 1 negative tau times H tilde when it comes to the eligibility, determining the eligibility of the person. Okay. Here, tau is the associated transaction cost regarding the liquid housing assets. We go to the couples qualification rule. If none of them are in nursing home, then you have the rule for 2 times A bar regarding the nursing home stay is equal to 0. But if one spouse is going into the nursing home, still there is another community spouse that's still living in the house. So then in this case, the eligibility rule is not adding the housing assets. In contrast, when both of them are in nursing home, then home is no longer home for this married couple. So that's why we have H tilde that's added to the A tilde. Okay? That's how we sort of incorporate this homestead exemption rule in our current framework. All right. So before I move on to the estimation section, this is 1-page summary of recursive formulation for couples. So here, state vector ZT includes time varying and time invariant state variables. AT denotes liquid assets, H tilde are housing assets, and SH and SW are health status for husband and wife, respectively. We also have time invariant state variables as Y, which is income, and IC, child, is the availability of informal care from children. It's either 0 or 1. The choice factor include house selling and renting decision, spousal care given, and general consumption that's relevant for husband and wife also. Husband's consumption and wife's consumption could be different if one person goes into the nursing home, for instance, okay, who will get the basic food and housing services provided by the nursing home stay. And then in the first line of this recursive formulation, you can notice that the flow utility is expressed as the weighted average between the flow utility of husband and flow utility of wife. And if the wife decides to provide spousal care for the sick husband, then this psi term that's related to this utility of spousal care will incur. Okay. And here kappa captures the bargaining weight between husband and wife. Pi denotes the survival probability that varies by health, age, gender, and income. And you can see that in the third line, if the husband dies with probability 1 negative pi h, then husband will get the bequest utility VM that depends on non-housing asset and housing asset. Whereas if both people dies, then they'll get the bequest utility of singles. Then that sort of summarizes our model section. Let me move on to the estimation session. So here I'll be brief about how we do the estimation. We estimate parameters, some parameters outside of the model, including health and mortality risk, estimated using the HRS data. And then we estimate the remaining key parameters using the simulated method of movements. These key parameters include caregiving disutility, depending on home ownership status. So if the disutility parameter for homeowners for spousal care provision is estimated to be smaller than for renters, then this sort of this sort of supports our conjecture that there exists complementarity between home ownership status and spousal caregiving. We also estimate Pareto weight, bequest utility, and weight on housing utility, for example. The estimated model replicates key patterns of the data quite well, including long-term care arrangements, home ownership rate over the life cycle as follows. So this shows the currently couples and currently singles home ownership rate over the life cycle across different income groups. We consider low, mid, and high, and our model does a fairly good job in terms of matching this life cycle profiles. And also our model matches home ownership rate around the time of spousal death. So in the introduction, I showed you a motivating figure that there exists a reduction in home ownership rate around the time of spousal death. And our model can also capture that pattern successfully. All right, then having our structural model, what we can do is the counterfactual analysis and decomposition analysis. So first, what I'd like to show you is the decomposition analysis. Okay. In our baseline model, we incorporate spousal care, Medicaid's asymmetric treatment of housing, and heterogeneous bequest motives. So what we will do is we shut down each of these 3 channels and look at counterfactual home ownership rate. So here, this slide shows the baseline difference in homeownership rate between couples and singles conditional on income. The circle solid lines are for couples, and dashed lines with cross marks are for singles. Across all income groups, there is a huge gap between couples and singles, and couples desave much slower compared to singles, as you can see. The name of the game here is to see under which scenario this gap is reduced by the most when a specific channel is shut down. So then, since we want to sort of incorporate these three channels that I highlighted in our model section, let's first look at the homestead exemption channel by Medicaid. When Medicaid goes after housing assets, not only for singles, but also for couples. So in other words, if there exists no favorable treatment for couples, then low-income couples' home ownership rate is reduced by a huge amount, as you can see on the left side panel. Okay? And then the gap seems to be almost gone, which is very surprising. And the reason is because low-income couples need to run down and there is no favorable treatment of housing assets. Okay? So that's why we see a very lower home ownership compared to the baseline case. For higher income couples or middle income couples, Medicaid doesn't seem to have influence because they do not qualify anyways. So this channel seems to matter the most for the low income households. Let's move on to the next channel regarding the spousal caregiving. So here, what we are thinking about as the counterfactual experiment is that when there exists no spousal caregiving for sick husbands, then what we find is that it matters the most for middle-income couples. Middle-income couples' home ownership rate falls significantly. If you think about middle-income households, middle income is not too poor to qualify for Medicaid nursing home, and they don't have much money to afford nursing home paying out of pocket. So spousal care channel is important for this group, and this sort of highlights the insurance for nursing home risk provided by the family member. The last channel is regarding the bequest utility. So if married households also only value bequeathing liquid assets, then the home ownership rate will be much lower for higher income married couples. And this channel is important or substantial for high income couples only, or high income couples only. It's because low income and middle income, they don't have much to leave behind as bequest anyways. Okay. So in summary, we found that there is a substantial heterogeneity in why couples hold on to housing assets. For low income households, they seem to hold on to housing to better qualify for Medicaid. And for middle income, holding on to housing is regarding the spousal care given. And for high income groups, then they don't desave housing to leave bequest towards surviving spouse. Right. So for the remaining time, I'll present some results on policy experiments. Our measure of welfare is as follows. We first compute the mean wealth transfer needed to make a household under the baseline regime indifferent to the counterfactual scenario. If this transfer value is positive, then this means that the counterfactual setting is desirable. From here, we need to think about the cost side too. So we subtract the mean change in present value government expenses. Then what we will do is we first consider subsidies for spousal caregiving. Currently, US doesn't have a policy like this, but Germany, for example, implemented cash transfer to family caregivers, which is close to $5,000 per year. We also conduct policy experiments considering alternative treatment of housing and Medicaid eligibility. And we show from our decomposition analysis that this channel could be very important for low-income households. So we will evaluate welfare considering three potential cases. The first case is when housing is always recovered. So in other words, nobody, or regardless of being single or married, the housing asset is not, housing asset is always recovered. So housing asset is counted in terms of eligibility condition. Okay. The second experiment that we do is always disregarding housing when it comes to eligibility, so favoring both singles and married. And the last counterfactual is favoring singles in contrast to couples. So this last counterfactual, you could think of this as the reverse of the status quo policy. So this is the one-page summary of the welfare analysis of counterfactual policies. On the second column, you can see the effect of the spousal care subsidy. Okay. So first, on average, you can see that in terms of wealth transfers, it's all positive and it's very substantial. So you can see that on average, households will be better off for all income groups. And this is not surprising given that you will get a spousal care subsidy, which was not existing before. But then government needs to incur care subsidy expenses. So that's why for the care subsidy part, we have $6,800 per household for government expenses. Okay. However, with this care subsidy, because the spousal care rate is a lot higher, fewer people will rely on formal long-term care services, reducing the Medicaid spending for governments. So that's why overall government spending is increased only by a small amount. So the net welfare effect, which is written in red, is about $8,000 per household. For column 3 to 5, this shows the policy experiments for alternative housing treatments in Medicaid's eligibility rule. So the third column is when government goes after housing, not just for singles, but for couples too. In this case, you can see that low-income households are substantially worse off. They need to draw down all their assets in order to qualify for Medicaid. And also, it does not save any money for the government, although they made Medicaid more strict. This is because low-income households run down their assets while they're still young and married, and faster de-saving of retirement wealth, which increases the chances of qualifying for Medicaid. So this sort of imposes the higher Medicaid expense burden for the government. So the net welfare effect is negative $3,000 per household, although the Medicaid became more stringent. The fourth column is when Medicaid becomes more generous. Obviously, households are better off, but way too many people become eligible for Medicaid, so net welfare effect is usually negative. Lastly, when couples become worse off, but singles are better off, in this case, when there exists favorable treatment for singles only, the wealth transfer looks different across income groups, right? So for low income groups, it shows negative value. For middle income groups, it shows positive value. So low income couples are significantly worse off. In other words, low income households prefer to enjoy homestead exemption while they're married than they're single. This is because by the time the low income households are single, they have very little savings anyways to qualify for Medicaid, even without the exemption. However, low-income couples are so much worse off without homestead exemption because they need to run down all their assets in order to qualify for Medicaid. All right, so this experiment sort of provides homestead exemption to couples only, which is the status quo policy, encourages slower de-saving of housing wealth, which decreases the overall impoverishment risk in retirement, which sort of justifies the status quo policy. So let me conclude. In this paper, what we found is substantial heterogeneity in why couples de-save housing wealth at a much slower rate than singles. For low-income people, they hold on to housing assets to qualify for Medicare without exhausting all their retirement wealth. For middle income, spousal caregiving channel seems to matter, whereas for high income, this seems to be bequest motives towards surviving spouse where housing is very valuable. Okay. And then we also experimented with provision of care subsidy, which seems to be welfare improving while almost budget neutral. And the current treatment of housing wealth by Medicaid seems to be desirable according to our framework. So that's it. Thank you very much for your attention.
Thank you, Minsu. That's great. Okay, we're eating a little bit into our break, but we will have time for some questions. We have 3 of them at least. Is Gia here? Or is that one on Zulip? Well, we have one that came through Zulip, and it's, could it be another channel that singles are more likely to sell their housing because they prefer cohabiting with the children?
Okay, so in our current framework, we are not having, when they become single, they move to live with their children. But now we're trying to get hold of the restrictive data set from HRS to see whether this geographical movement after marital transition happens, whether that part of desaving of housing assets is significant in the data. So that channel is abstract, but we're thinking of incorporating, or at least looking at it in the empirical data.
Okay, another question about children. I wondered if you could use the existence of children that you marked as a possibility for informal care to modify the bequest motive as well for both singles and couples.
So you're saying that having the children that goes into the bequest utility, that's your suggestion?
Yeah, you said that was the suggestion. He doesn't have the micro. I have the microphone back here.
Yeah. So yeah, as of now, we're just capturing the bequest motive. That's average bequest motive, but we could potentially looking at or modeling having an additional term that comes related to whether there was children or potentially number of children. But yes, yeah.
A question from Eric French.
So I was curious about how in the model, the tax treatment of housing works. So back in the olden days, I think lots of old timers like Eric Engen and people like that, they were very into the fact that households should optimally run down their financial assets before their housing assets, just because housing is tax advantaged. And and the reason for that is, you know, the value of rent that an owner has from their own home, they don't have to pay taxes on that rent. Whereas, of course, if we rented and had liquid assets, we'd have to pay taxes on interest. And I was curious how you had modeled that, and also whether or not this was important or whether the Medicaid channel is really more important.
I see. Thank you very much for your comment. So the tax treatment that you mentioned is not incorporated as of now. Of course, there could be different tax treatment for example, mortgage payment, but we both looked at the housing value that's constructed based on the net housing value, considering these mortgage payment deductions. Since we're looking at old people, this margin seems to be negligible, but of course, the tax treatment regarding the housing, the property itself, it's not considered in our current framework. So yeah, I mean, that's what I can say as of now.
Thanks so much, Minsu. Great presentation, and we'll see you next week sometime on campus.
Yes.